The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. It's 9 o'clock in the morning, and it is Tuesday, and it is January 4th of a new year. So this is a new year in which we are continuing our webinar series. It's the band Aerosmith, I believe, that we just heard. And for the next maybe couple hours at most, but I don't think that long, you'll be hearing the voice of me, Dr. Minarsik. And this is going to be our second discussion on what we called GU, or genitourinary. We started the first one last weep, GU1, strictly talking about overall kidney diseases, and in particular the glomerulonephropathies or glomerulopathies. We're going to continue and finish the discussion of renal diseases today, and we're going to do everything except the glomerulopathies because we did that before. What else can I say? It's Tuesday, if I didn't say that. It's also extremely cold these days in Chicago. Yesterday it was almost 0, so if my brain starts to freeze, I can't blame it on old age. It's still rather warm in here, but just about a foot away from my hand here, it could be in the single digits again. So let's rock and roll. Let's start out with what we're going to talk about today. And what we're going to talk about today is the same picture I've already showed you a couple of times. We've already covered the glomerular diseases, which you see here. Today we'll be talking about the tubular diseases, which most of this frame is. And we're also going to be talking about the vascular disease. You can see a nice artery there. It's a pretty big one. I don't know, maybe it could be an arcuate artery. I don't know. And specifically, we'll be talking about diseases of tubules and interstitium. Sometimes the concept of tubules and interstitium are taken together because if you have some disease, especially the inflammatory diseases involving the tubules, you're probably going to have it spread into the interstitium, which is the space between the tubules, and vice versa. If you have an interstitial process, perhaps inflammatory disease or whatnot, it's going to involve the tubules as well. Then we talk about various diseases of the renal blood vessels, and we'll talk about the concept of obstruction, at least from the standpoint of the upper urinary tract. We'll be talking about obstruction a lot more when we get down next session to the lower urinary tract. And finally, we're going to make you smart and tell you all about the common type of renal tumors, benign and malignant, okay? So here we go. What are the general things that could happen to the tubules? Well, there's a very specific syndrome and pathologic condition called acute tubular necrosis, related to ischemia, but also related to toxic substances. There's the concept of inflammatory diseases in general in the kidney, but not necessarily involving the glomeruli, called tubulo-interstitial nephritis. Sometimes it's primarily tubular, sometimes it's primarily the inflammatory diseases between the tubules, but generally they're taken together. The most common of one is the infectious disease called pyelonephritis, usually from the ascending gram-negative bacteria, but there's a few others you should be aware of. Finally, the drugs that could cause inflammatory changes in the interstitium and tubules, as well as some toxins. Could stones like uric acid stones or calcium stones also damage the tubules? Of course they can, just as much as they could damage anywhere else in the lower parts of the urinary tract as well. Finally, a disease called multiple myeloma. We've dealt with it before, but it could damage the tubules in two ways. One of it is to load it with proteins, which are the immunoglobulin light chains called Bence-Jones proteins, and also the fact that multiple myeloma is related to an accumulation of other immunoglobulin proteins called amyloid, which can affect anything, but specifically has a pretty good predilection for the kidneys as well. Okay, so what's acute tubular necrosis? You know, all of the hot shots just call it ATN. It's actually a destruction or a true necrosis in the classical sense of the word of the renal tubular epithelium. Remember, there's the proximal tubules, there's the distal convoluted tubules, and as a result, as you would expect clinically, there's a loss of renal function. And amazingly, about half of acute renal failure is due to acute tubular necrosis. And the majority of this is because of the fact that people that are in shock are not perfusing their kidneys very well. In fact, they're not perfusing anything pretty well. So probably most of these cases of acute renal failure due to acute tubular necrosis are secondary to shock. Okay. Now, There's two kinds, and don't think they're entirely separate because they can be combined with each other. The first kind is the classic kind, is the lack of blood flow to the kidneys. Ischemic acute tubular necrosis. But there are also compounds, and probably the most likely or common of which are regular drugs in the general field of antibiotics, but also contrast agents have been known to produce it as well, and that's with or without the contributions of ischemia. The aminoglycosides have always been at near the top of the list of causing ATN, as well as amphotericin B. Now, there's a few others. So once again, the advice is to any antibiotic, you should be checking for side effects, and particularly nephrotoxic side effects. And the contrast agents, they're not exactly a thing of history. I know they've improved them greatly, but in the past they were also a pretty common cause. Now I think they are relatively rare from what the radiologists tell me. So how about if we look once again at a normal kidney? This is about the fourth time you've seen that, but you do see nice cellular arrangement in the glomeruli. You can see cells with nuclei in the walls of the blood vessel. But look at all the rest of these things are tubules. Now, what is the one thing that you see in the tubules? What you see in the tubules are cells. Okay, the cells have nuclei. Do you remember the classic findings of cells that are necrotic? Well, they lose their nuclei. They become karyolytic. In other words, first the nucleus becomes smaller, darker, and then it starts to dissolve. And probably the majority of these tubules, they're completely necrotic because they've lost their cellular definition, and basically the whole cell is nothing but coagulated proteinaceous material. Not all of them. In fact, for those of you who have a good, keen eye, you could tell that a few of these tubules, like here, and maybe here, are what you would call the distal convoluted tubules. And they seem to be a little bit better preserved than the proximal convoluted tubules. Do you think that means maybe the proximal convoluted tubules might have a little bit more of an oxygen demand than the distals? That's what I would assume. But basically, we shouldn't separate them. Most of the tubules in this picture, in the cortex of the kidney or the columns, okay, are necrotic. They've lost their definition. It's like looking at a kidney, but the tubules have no nuclei. Okay. What causes it? Well, incredibly obviously, if you deprive something of oxygen, if you deprive it of blood, it's going to become necrotic. And that's exactly what we're seeing. It's as simple as that. But also, separate from that, in the second type of ATN, we can have nephrotoxic compounds. We talked about the antibiotics. We talked about the contrast agents, which produce a similar picture. And quite frankly, if I showed you one that was caused by primarily blood flow problems versus tubular injuries, you couldn't tell the difference because they both look pretty much the same, which means like this. So take a quick picture with your mind, because half of your patients in acute renal failure are going to have kidneys that look like this, okay? Clinically, patients with ATN within a fairly short period of time, not much more than a day, develop oliguria, loss of kidney function, inability to make urine, obviously, azotemia, a rising BUN, rising creatinine. And then after that first day or so, it continues and it gets worse, okay? More oliguria, more azotemia. At that point, we're in acute renal failure here because we're only a couple days from normal kidneys pretty much. And so they go on dialysis. And with dialysis, you would expect that there could be some healing or recovery present. And yes, that does happen in many cases, except when, of course, the shock is irreversible. The main problem in the recovery period is that they develop hypokalemia. Okay, so once that potassium starts to come back up again, you would hope by then the BUN creatinine also returned to normal. So that's it for ATN, half of all acute renal failure. Now, the big inflammatory disease of the kidney is pyelonephritis. Okay, the classical pyelonephritis is an ascending infection from the lower urinary tract, and the common organisms that are called the gram-negative coliforms, like E. coli is always at the top of the list, but Proteus, Klebsiella, Enterobacter, and these are things that are usually normal flora of the GI tract, aren't they? Strep fecalis, okay? But if they somehow get into that urinary system and travel upwards, then we have a pyelonephritis. That's a classical and most common type of a scenario or pathogenesis. Now, of course, they have to come up by ascending, but if there is urinary reflux or some degree of obstruction in that lower or even upper urinary tract, that's basically what happens. Could you have a pyelonephritis in which you have a septicemia and it is acquired rather than from a lower urinary tract infection be acquired hematogenously? Yes, so that's not as common as the ascending, but it's also seen fairly often. Now, I don't have to show you too many pictures because we've been dealing with this kind of classical thing all year. You can have acute pyelonephritis. It corresponds with acute onset of the disease, in which neutrophils or polys are the main cells infiltrating the tubules. Or you could have chronic pyelonephritis, in which mononucleated cells, lymphocytes, macrophages are the chronic thing. And also, chronic pyelonephritis is classically followed by a scar or fibrosis as well. So I'm going to show you some pictures right here, and it's not going to be a quiz, but I'm going to say, if you saw a kidney here, and you could see that the tubules are damaged, but you can also see that the majority of the cells within these tubules are neutrophils, okay, polymorphonuclear leukocytes. Then you could very easily diagnose this as acute pyelonephritis. If they was more severe, could you see abscesses? Of course you could, just like we saw in the lung or just about anywhere else. Now, here's another question. I'm going to show you another picture of pyelonephritis, and I'm going to ask you if it's acute or chronic. You know this is acute because you have neutrophils. But what about this guy here? What do we have here? Well, we have kidneys. I think you could recognize that. But you can also see that there are these deep, what they classically describe as deep, pitting, broad-based scars. So anything that's basically scarred, is the result of a chronic inflammatory process. So this is chronic pyelonephritis grossly. Okay? What about this? We have tubules here. We don't have polys, but we can see that there is inspissated proteinaceous material within these tubules. This was a really good picture I've used for a few years, but I found, I think, maybe even a better one last night. And I'm going to show you another picture. And I'm going to ask you a question. If I told you this was a thyroid gland, would you believe me? And you'd probably say yes. In fact, I could probably even fool a few of my pathologist buddies very quickly as well. In this, we have the tubules are no longer filled with fluid, but they are filled with inspissated proteinaceous material. I never got the exact chemical composition of what it is, but I imagine it's protein from the degenerated cells because look, can't you see most of the epithelium is flattened here? So this is chronic pyelonephritis. And the specific term that they often use to describe microscopically chronic pyelonephritis is the term thyroidization, because it looks like thyroid. And you know, there's not too many things in the body that look like thyroid, except for thyroid, but chronic pyelonephritis is one of them. And I think maybe a lactating breast might be another one. And there's also the intermediate lobe of the pituitary that looks like it has thyroid follicles too, but that's just an interesting aside comment. So, what causes pyelonephritis? Well, we said that ascending infections from the lower urinary tract, maybe there's a reflux, or maybe somewhere along the line there was a blocking of a duct. Here, and let's take this concept of blocking now, as long as I put that in there last night. I want to explain something which I think by now should be pretty obvious. Maybe not, but we've seen so many examples of it in this course so far. Any tubular structure in the body, whether it's microscopic, whether it's gross, anything that's a tubule that transports cells or fluid or secreted material, you know, think of just about any tubular thing, any gland technically, okay? If the duct gets blocked because of any intrinsic process or an extrinsic process, and the material which is supposed to flow through that duct, and I'm even including blood vessels, okay, sets up the stage for inflammation, okay? And there's no exception here in the kidney either. If you have anywhere along the drainage path of the upper or lower urinary system, we're talking about upper right now, and there's some kind of blockage, okay, the material which is supposed to travel through it gets inspissated or perhaps blocked or sluggish or completely stopped, then that sets up the stage for inflammation, particularly if that material now becomes necrotic, okay? But it doesn't have to be necrotic, it could just be irritating, that's all. So obstruction is the big factor in pyelonephritis. You could have what they call a congenital UPJ obstruction, you know, a kinking of the ureter close to the kidney would be an example, or something that's acquired, perhaps a tumor pressing on it, perhaps a blood clot, perhaps a stone, okay? People that have instrumentations where the mucosa of the upper or lower urinary tract has been irritated or instrumentated and now inflamed could be a factor for obstruction as well as inflammation, depending on how badly the mucosa has been damaged, okay? One of the common things also, there is a valve in the lowest portion of the ureter, and it's supposed to be a one-way valve. It's supposed to transport basically sort of sterile urine into the bladder, and it's not supposed to come back again. But in reflux problems with the valve, pressure problems, even congenital problems, this could be another factor for an ascending urinary tract infection all the way up to the kidney. Just because it's in the region of the bladder and the ureter, that doesn't mean that that urine can't ultimately find its way all the way back up to the kidney. Do you think pregnancy could be a factor? Do you think that pregnant women frequently don't develop urinary tract infections simply by virtue of the fact that there is a huge thing inside their abdomen which puts pressure on the retroperitoneum, you know, which is where the ureters are? Of course, pregnancy is a very common factor. Age, of course, is a factor. Older people tend to get more likely some type of obstruction and secondary inflammation, and also sex. Females, much more likely, I got 3 little arrows there, to get a urinary tract infection than a male. And I think you know the reason for that, okay? Because the female urethra is what, maybe about 1 centimeter long? And the male urethra, well, classically, every guy will say 6 inches long. It's as long as the penis, okay? Now, of course, some guys will probably tell you that their urethra is 9 inches long, but you know that's a lie, okay? That's a joke as well. Any type of previous lesion that may have been an obstructing factor could be a factor again, and also secondary inflammation. And we all been talking about risk factors and external etiologies, but what about the patient's immunity? Do you think any type of immunosuppression or immunodeficiency would be a likely factor for an inflammatory or infectious disease? Of course. But remember, even though we rattled off, 1, 2, 3, 4, 5, 6, 7 factors, they're not entirely separate. And if you wanted to generally have a bad memory like me and can't remember all 7, you say the key recurring processes are ascending infections, in other words, bacteria getting into the upper portions of the urinary tract, and also secondary to perhaps blocking as well. What if you don't have specific organisms causing a nephritis, and specifically the drugs and toxins are often described as causing an interstitial nephritis? In other words, the primary focus of inflammation not being primarily limited to the tubules, but that interstitium between the tubules. The synthetic penicillins are always at the top of the list. A drug which probably is not used too much more, but it can be, rifampin, and probably one of the most commonly used drugs ever, the thiazides. These are 3 drugs which classically have been frequently indicted in causing inflammation, a non-infectious inflammation of the upper urinary tract, in other words, the kidneys. Okay, but once again, and I'll say it again, I've said it before, any drug that your patient is on should be carefully checked in the package insert to see if there's some type of association between it and renal infections, renal inflammation at least. Okay, in a person on a certain drug, they might be on it for a week or 2. That's the classical scenario. They then develop a fever and eosinophilia, not just in the inflammatory infiltrate in the kidney, but also an increase of eosinophils in the peripheral blood, perhaps a rash, because it's like an allergic reaction to the drug, okay? And that allergic reaction classically is characterized often by eosinophils, okay? If it was primarily an infectious problem, perhaps the primary cell would be a neutrophil. But when there's a lot of eosinophils in the inflammatory infiltrate, think of allergies, think of drugs, okay? And of course, an acute renal failure type of picture. In other words, a relatively rapid rise in the BUN and creatinine. Okay, what is this again? Well, I think I can convince you easily it's kidney. I think I could convince you easily it's cortex, or perhaps not an area where there is very few glomeruli. And I think I can convince you that these are tubules. But let me ask you the question, is the primary focus of these inflammatory cells, like pyelonephritis, within the tubules or between the tubules? That's why these are called interstitial nephritis, okay? This drug-induced type of situation. Okay, another drug to be very, very aware of are your regular old NSAIDs, your non-steroidal, non-selective also, anti-inflammatory drugs. Aspirin, Tylenol, okay? These are drugs which could potentially be nephrotoxic depending on the amount of dose and the amount of time the patient sits on it. And they can cause a tubulointerstitial nephritis as well. And it could be severe. Okay, so a severe damage to the collecting system might actually result in the actual necrosis of the renal papilla. So like if you cut a kidney, okay, and you're looking basically at the pyramids, okay, the tip of the pyramid is called a papilla. Why is that hemorrhagic and black and necrotic looking? Is because the papilla is necrotic. That's papillary necrosis. You can see evidence for it here. You can see evidence for it here. You can see evidence for it here. And these papilla can actually, being necrotic, break off and obstruct, into the lower portions of the collecting system as well. Okay, now papillary necrosis, of course, is not specific for analgesic nephropathy. It's also often seen with sickle cell disease and diabetes as well. So here's a normal kidney, and here you can see the tips of the papilla, like there. Whoops, let me make that a better arrow. Are pretty normal, and there, but up here, they're hemorrhagic and necrotic. So this is a great picture of papillary necrosis. What about stones? Could they damage the tubule? Of course they can, because that's where they would concentrate. Any stone that you see in the kidney, any stone that you see in the ureter, can also be present in the upper urinary tract as well. Okay, calcium stones, uric acid stones, all the typical types of stones that you see, which you would call a tophus, for example, with gout, can also be microscopically present in the tubules higher up in the system. Now, uric acid crystals or sodium biurate, okay, can collect in the tubules, can cause damage to the tubules, and obstruction, anything higher than it. They could also form lower in the urinary system as well. When you want to document the fact that these damaged tubules are caused by urate stones, you don't normally fix it in formalin, which is what pathologists like to fix everything in, because the formalin basically dissolves the uric acid crystal, okay? So they usually fix these in alcohol. So if you have them fixed in alcohol and you see something like this and you want to document it as being uric acid, well, what do? You polarize it under light microscopy, and it has a nice refractile, brilliant sort of shining color like this. Okay, could you regard these as mini tophi? Okay, microscopic. Yeah, you probably could. Do you think that somebody with a kidney like this might also have larger stones, further down, in the ureters or in the bladder? Of course. Okay. But this is urate nephropathy due to the presence of microscopic stones obstructing and damaging the tubules. And you probably know what I'm going to show you next. Calcium. The calcium stones, calcium oxalate stones, technically are the most common type of stone in the lower portion of the kidney, bladder stones, okay? But they can also, in cases of significant hypercalcemia, differential diagnosis of hypercalcemia, being hyperparathyroidism at the top of the list, but there's other conditions, renal conditions, as well as things like metastatic disease, okay, in which there's been widespread destruction of bone, okay. So they can also precipitate in the tubules and interstitium and cause eventually loss of renal function as well. And that would be called nephrocalcinosis. And of course, the etiology or cause of it is hypercalcemia. The higher the blood calcium level is, the more likely it is to form stones in the tubules. Yeah, let's see if we have anything else left here. Oh yeah, multiple myeloma, okay? That's another really good example. One of the common findings in multiple myeloma is the presence of protein in the urine. And this protein is very easily detectable by usual means, but a certain type of protein called Bence-Jones protein, which is the light chains of immunoglobulins, gamma G, gamma M, okay? Not only is in the urine, but it can plug up the tubules in the kidney as well. And also remember, multiple myeloma being a disease in which there is a chronic and often massive buildup of immunoglobulin other than in the urine, and can deposit into tissues and cause these hyaline deposits called amyloidosis, is also another reason for multiple myeloma damaging the kidney. Now, here's a proteinaceous material within a tubule. All you could say is that it's red, it's uniform, it's what we would call hyaline. It could be any type of protein. It could be the protein that you see with chronic pyelonephritis. But if you do a special stain called a Congo red and looked at it, it would be red. That's why it's called Congo red. But if you then polarized it, okay, it would then be what they call apple green, or what they call granny apple green birefringence under polarized light. Okay, so that's another reason, two reasons actually, why multiple myeloma could damage the tubules, okay, Bence-Jones protein. And don't forget, the amyloid, of course, is not specific for the tubules. I believe this, to me, looks like an actual glomerulus over here. But there's other areas like that. So amyloid can just build up anywhere, not only in the kidneys, but anywhere else in the body. Okay, let's see what we have here. Now, if you remember, this is probably about the 5th time we saw this slide. We talked about the glomerular diseases. We talked about the tubular diseases. And you could probably guess what we're going to talk about now, the vascular diseases. Okay, well, and we're making very good time, and it's pretty early. And this is not going to be a long webinar, so, we're already probably more than halfway done with the material for today, and it's only 9:30. Maybe we'll be out of here pretty early today. So how about if we take our music break now, and when we come back, we'll talk about the vascular diseases, perhaps more on obstructive diseases, and finally the tumors. So we'll see in about 10 minutes, and we'll have some more good old-fashioned rock and roll during that time. Okay, see you in a little bit.
the Florida Keys. There's a place called Kokomo. That's where you wanna go to get away from it all. Bodies in the sand, tropical drink melting in your hand. We'll be falling in love to the rhythm of a steel drum band. Down in Kokomo, Aruba, Jamaica, ooh, I wanna take you through Bermuda, Bahama. Come on, pretty mama, Key Largo, Montego, baby, why don't we go down to Kokomo? We'll get there fast and then we'll take it slow. That's where we wanna go. We gotta go, Martinique, that Montserrat mistake. We'll put out to sea, and we'll perfect our chemistry. By and by we'll defy a little bit of gravity. Afternoon delight, cocktails and moonlit nights. That dreamy look in your eye, give me a tropical contact high. Way down in Kokomo, Aruba, Jamaica, ooh, I wanna take you through Bermuda, Bahama. Come on, pretty mama, Key Largo, Montego, baby, why don't we go down to Kokomo? We'll get there fast and then we'll take it slow. That's where we wanna go. We gotta go. wants to know. I close my eyes and just let go. Just let go.
You guys are probably wondering, where the hell are these songs coming from? I never heard them before. Let me tell you, some of these were really old songs and old groups like the Beach Boys, Air Supply. You know, these are groups that probably around, before your grandfathers were born, okay? But this is my favorite rock and roll from the past, okay? Also, I decided to get a little bit warmer in the second half because even though my house is pretty well heated, I'm near some big not open windows, but windows where I have to let the light through, so it gets a little chilly here too. Put on a little sweatshirt as well. But the big thought that I got in my head during the break was this concept of guilt. Because here it is, if you look at the clock, it's only about 9:45 right now. And usually after the first half, we're well into the second hour. So we are really speeding along there. And usually when I decide what we're going to talk about for a webinar, I go to the previous year's material and I give myself plenty of time to talk about it. The thing that I don't want to do is run out of time. I'd rather leave a little bit early, close the webinar a little early than stay late, because and everybody is mad, including myself. So today, the good news is, if you really got other things to do, this is probably going to be one of the shortest webinars. We could be done now in maybe a half hour or so, even before 10:30. We usually go to 11, but let's get going, okay? Let's go, Brandon. So let's close the guy again and talk more about the 2 or 3 other main important things we'll be talking about. And that'll be vascular diseases and obstructive phenomenon and tumors. Once again, there's your big picture. Always remember that renal pathology is 3 things: glomeruli, tubules, and blood vessels. We'll talk about the blood vessels or vascular diseases. A very common condition, you would think if it was called nephrosclerosis, it would have something to do with narrowing or fibrosis of blood vessels within the kidney. These can occur in a sort of a benign way and are very, very often associated with old age and atherosclerosis and even hypertension. But when the blood vessels show active destruction, that is very often a picture of what we would call malignant hypertension. In other words, extreme hypertension that has a high morbidity. Could you have a stenosis of the renal artery? Of course, you could have stenosis of any artery. Probably the most common cause in adults is atherosclerosis, an atherosclerotic plaque maybe. But there's also a condition which is not atherosclerosis, and in younger people, and generally not just a problem with the intima, but actually involves all 3 layers of the renal artery. Then we have this family of what is often confusing called the thrombotic microangiopathies. In other words, diseases of the tiny blood vessels, perhaps the capillaries even. And there's two syndromes seen in both children and adults. One of them is called hemolytic uremic syndrome. Another one is called TTP. And I was always taught that these are two separate syndromes. However, as time and science has built up, it's actually discovered that they are so closely related. Sometimes they're considered as basically the spectrum of one disease now. Could a kidney have a thrombus and result in an infarct? Of course it can. Could it be so terribly compromised in the vascular thing that you can actually have a diffuse cortical necrosis? Or do you remember in the spleen with the microinfarcts, the spleen became completely small and fibrotic? Well, a similar picture you could see in the kidney of sickle cell patients as well. Here's your normal picture again. I'm sure that looks familiar by now. And take a look at this. Here's a good sized blood vessel. But look at the lumen is just a tiny thing there, a tiny thing there. Maybe it's cut again and you get a tiny lumen there. This wall of this blood vessel, it looks like it's a pretty good size artery. Maybe a segmental or arcuate or interlobar, I don't know. It's hyalinized. It's sclerotic. But the blood vessel itself, the wall, does not show an active destruction or inflammation. This is what we call benign nephrosclerosis. It's very, very, very common. And I bet you that if you talk to any pathologist that has done autopsies on 1 million elderly sick people, he'll probably say he probably sees stuff like this, and probably way more than half of them. And basically all it is hyalinization of the arteries and small arteries too. If you remember, atherosclerosis is not usually a disease of small arteries or arterioles. Okay, in nephrosclerosis, like in diabetes, for example, you're going to get damage or sclerosis of the small vessels too, or arteriolosclerosis, not just arteriosclerosis. So I know what you're thinking. Is this just a part of routine atherosclerosis? And probably isn't. Okay, some of it could be related, but remember, routine atherosclerosis generally spares the arterioles, okay? It's very, very, very common. It could be both a cause or a exacerbation of hypertension, or it could be the result of a hypertension with damage to the small vessels. But it in itself is a separate disease from atherosclerosis, and it's separate from diabetes. And this is a great picture of it. But look, probably even smaller arteries in here are involved as well. This is more like an artery. You know, I bet you if we blew this up and looked at the slide more, which we'll do in the lab, we could see smaller vessels as well. Now, if I'm calling this benign nephrosclerosis, do you think there might be something called malignant nephrosclerosis? Yes, there is. But what's the difference between benign nephrosclerosis and malignant nephrosclerosis? Or if you want to call it malignant hypertension, you can. Because whereas benign nephrosclerosis had an association with hypertension, malignant nephrosclerosis has an association with progressive, severe, and often fatal or malignant hypertension. And once again, it's not a part of routine atherosclerosis, because atherosclerosis, the arteries are basically damaged, but they're stable. They're hyalinized perhaps, okay? But in this malignant nephrosclerosis, the arteries are actively being destroyed, okay? And they have two pictures, which I'm going to show you. once again, like with the benign, there's a significant luminal narrowing, but in malignant, you have active vascular damage, and you have an actual necrosis, not just a hyalinization, but a necrosis of the blood vessel. Remember, we said that blood vessels that are necrotic are often given the name fibrinoid necrosis. And also, blood vessels that are damaged aren't just hyalinized, but they have kind of a laminated or circular thing like an onion skinning, which we're going to show you a good example of. Here's an onion. That's the best way to show you. And you see, when you cut through an onion, you have these layers. In other words, there's like little layers in the wall, relatively lamellar or concentric. And here is a arteriole. You can see it's next to a glomerulus, and it has that same layering effect. So if I was just to cut this little thing out and tell you it was a picture of an onion, you'd probably believe me. And here, take a look at this blood vessel here, also with malignant nephrosclerosis. You could tell the wall is not intact, but you could tell it's totally fragmented, totally damaged. And if you were to have something in this kidney that also was fibrin, it would have the same staining problems of fibrin. So that's why they call it fibrinoid necrosis, but it's not fibrin in itself. It's a little bit pinker than most of the other stuff, a little bit redder than most of the other eosinophilic stained material in tissues. So what are the two features of the arteries in malignant hypertension associated with a progressive, serious, and sometimes fatal hypertension? It's onion skinning and fibrinoid necrosis, active arterial damage, not stable hyalinization like you get with so-called benign nephrosclerosis. Number one vascular disease of the kidneys. Here's something that is not that common, but you'll see cases of it. It's a relatively rare cause of hypertension. It could also be associated with the kidney being small, simply because chronically it's not getting enough blood supply. And if the patient had a significant atherosclerosis, it involved the renal artery, perhaps one big plaque, or just a general significant atherosclerosis in general, that would be the most common cause of renal artery stenosis. And of course, why would there be hypertension? Because you're hypoperfusing the kidney, and ultimately it kicks in that RAAS axis, which retains sodium and causes hypertension. Okay, but there's another type of renal artery stenosis that is not basically associated with regular old atherosclerosis. It's in generally younger people, and in general it has a predilection for women, younger women rather than men, okay? And they call this fibromuscular dysplasia. And of course, dysplasia does not mean malignant or pre-malignant. It means that it's, once again, just an abnormal growth. So like with atherosclerosis, you're basically having an intimal process which can become prominent. But in fibromuscular dysplasia, it also involves the media or the muscular layer, and even thickening of the connective tissue outside the artery of the adventitia. So fibromuscular dysplasia, all three layers, atherosclerotic renal stenosis, basically an intimal, a relatively specific intimal proliferation. Can I convince you that this general vague shadow here is a kidney? Can I convince you that we have some branching of the segmental arteries, of which there should be like about 5, but you can see 3 of them pretty good. Here's one, here's one, here's one. Maybe here's another one, but I'm not sure. So here, if you follow the origin now of this renal artery, with the main renal artery here, you can see a very, very distinct nick in it or narrowing, and that's because of atherosclerosis. Let's see if I could make that a little bit bigger. Whoops, I can, but then I screw this thing up. There you go. There's a significant atherosclerotic plaque causing decreased blood supply to this kidney. But in this type of renal artery stenosis, the fibromuscular dysplasia, younger patients and preferably women. Whoops, let's see if we could straighten that whole thing out a bit. There we go. We see that it is all three layers that are thickened. There's the intima, here's the media, and this connective tissue adventitia, a disease called fibromuscular dysplasia. All three layers of the renal artery are thickened, and that has the same pathologic effect as a significant atherosclerotic plaque. Okay? What about the tiny blood vessels now? That's why there's microangiopathies. They're also abbreviated in the acronym as a TMA for thrombotic microangiopathy, TMA. There's two syndromes in which you have fibrin plugs and damage to the tiny blood vessels of the kidney. One of them is called the hemolytic uremic syndrome. One of them is called thrombotic thrombocytopenic purpura, or the old classical TTP. Now, hemolytic uremic syndrome does have a familial type of association with it, and it could be in childhood or adult, and in childhood it often follows a Shigella infection, but it could be in adults. And TTP, you would think, would be a separate disease because it's a collection of small thrombi in the tiniest blood vessels of the kidney, including glomerulus, and as a result, it's a consumption coagulopathy because the fibrin and the platelets are consumed. Now, you would think that I was just describing two separate diseases here, but from a pathologic point of view, they are very often classified together as one disease. And I'll show you a picture right now of what happens in both of them. Here's a glomerulus. Here are the glomerular capillaries. They are filled not with blood, but something that stains even redder than blood, or fibrin. So they have these fibrin plugs inside the glomeruli and other small vessels. And as a result, the blood vessels are damaged. You have fibrin being consumed. You have platelets being consumed. You have factor VIII being consumed. All of the consumable clotting factors are being consumed, and that's why it's called a consumption coagulopathy. So it's a hemolytic process, and it's in the renal capillaries. And both of these two diseases have a picture that looks like this: HUS as well as TTP. And that's why the more we learn about these diseases, we more think that they're really part of the same thing. Okay, let's get back to the common things. Let's get back to things like vascular diseases like atherosclerosis or atheroemboli. What about damage to the tiny blood vessels of the kidney due to plugs of sickle cells, okay, microinfarcts? Or on a larger scale, damage to the entire cortex of the kidney. Now, as you might guess, the cortex has a much greater demand for oxygen in a kidney than the medulla does. So significant or chronic or sustained ischemia due to anything would be more likely, or at first, to damage the cortex. That's why it looks white over here. rather than the deeper medulla. Now, what happens in atherosclerosis? Well, we said atherosclerosis is primarily a disease of the larger arteries. The larger arteries have plaques. The larger arteries can often, and maybe even usually, have calcium or, cholesterol crystals in their plaques. So when you see an arteriole, which is not supposed to have atherosclerosis with these cholesterol clefts, these little needle-shaped crystalloid cholesterol clefts, you can assume that they came from an artery that was higher up. So that's what we would call an atheroemboli. These cholesterol clefts did not originate there. They came there from upstream in a bigger artery, perhaps of a plaque breaking off and showering downstream. Here is once again diffuse cortical necrosis, and it kind of looks like the entire kidney could be infarcted, couldn't it? But in an actual renal infarct, if you remember, the kidneys do not have a dual blood supply like the lungs and like the liver. They have end arteries, okay? So when you have a renal infarct and the part that becomes infarcted and necrotic is wedge-shaped, corresponding to the region of distribution of that end artery, and it's usually very well delineated. And because there is no secondary blood supply, it's not hemorrhagic like the infarcts in the lung or the infarcts in the liver, but it's actually white. Now, maybe even a little yellow perhaps as the infarct ages and you have influx of macrophages, chewing up necrotic garbage. But then it heals with the scar. So it goes from sort of a white to a yellow to a firm white, and that's the evolution of a renal infarct. I think I have a good picture here. Here we go. Could this have been perhaps a segmental artery? Could this have been the region of distribution, or perhaps an interlobar artery? It's a wedge-shaped triangular thing. You might even mistake it for a pyramid, okay, but it isn't. It's actually the region of distribution of the end artery. It's yellow. Perhaps it's relatively new then, perhaps days or weeks. But as time goes on, it becomes fibrotic, and the scar becomes white, and it actually contracts, as all scars do. Ultimately, they contract a little bit. And that's why you have that little notch along the surface of the renal cortex. I think I'm showing you these pictures to show you how to delineate a necrotic area from a non-necrotic area. Necrotic areas are red. So if you were to draw a line, you would say everything to the right of that is necrotic, and everything to the left and below is less or not necrotic. And you could probably draw a little line here, drive your car along this edge here, and saying that this entire reddish area is necrotic. And remember, we talked about tubular necrosis, in which primarily the tubules were necrotic. Well, in an infarct, or an area of diffuse cortical necrosis, which is like a big infarct, it's not just the tubules, it's the entire renal cortex or portion of it, which includes the glomeruli as well as the tubules. Okay, well, that's it for vascular diseases. Now we're going to talk a little bit about something we've already mentioned several times, but we're going to go into the concept of obstruction itself. We talked about obstructions with pyelonephritis being a causative factor, but think of all anatomically speaking, all of things that could obstruct the flow of urine, starting from the kidney itself and going all the way to the bladder. And I would think this would be a very, very logical visualization. We know that stones could do it. We saw tiny stones of uric acid and calcium involving the tubules. But what about further down? Could you have a stone obstructing a ureter? Could you have a stone obstructing the bladder? Could you have a stone obstructing the junction between the ureter and the bladder? Could you have a stone obstructing the urethra? Okay. Could you have a stone obstructing the three portions of the ureter, which are the most susceptible for narrowing or kinking or obstruction? One of them being at the junction of the kidney, or the UPJ, the ureteropelvic junction, one where it goes over the rim or the brim of the pelvis, and one where it empties in the bladder, okay? Could there be a congenital obstruction? Of course there could be, and these are common as well, especially at the UPJ level, the ureteropelvic junction. In men, without a doubt, the most common area for obstruction is an enlarged prostate, okay? And that's basically the proximal urethra, okay? Could you have a tumor obstructing the flow of urine, either from a tumor within the tubular collecting system or extrinsically as a metastatic, or perhaps a tumor of the colon pressing on a ureter? Inflammation in itself can narrow the wall of any part of the collecting system, so that's a logical pathophysiologic phenomenon. Could you have blood clots within the ureter or any part of the collecting system? Of course you can. Could you have sloughed papillae like we saw with papillary necrosis of analgesic nephropathy or sickle cell disease or diabetes? Do you think pregnancy could cause an obstruction? See, these are all, of course they can, okay? But these are all basically anatomic type conditions. You can also have a proper loss of innervation to the collecting system, the smooth muscle portion called a neurogenic bladder, loss of innervation to the bladder. Okay, could that affect the ureters as well? Probably not so much, okay? Stones, number one reason for obstruction anywhere. The most common type of stone is calcium. Calcium oxalate, calcium phosphate. But when you see a crystal in the urine under any condition, it's most likely calcium oxalate. 70% of all kidney stones or urinary tract stones have calcium. It's kind of interesting because when you look at the stones of the gallbladder, calcium is pretty rare. It's only like about 10 or 20%. But in the urinary system, it's the majority of them. The second most common type of stone, but far less common than calcium, are the so-called magnesium ammonium phosphate crystals. Okay, these are associated with bacterial infections. But another thing about them is that they are the most likely stone to be so large that in this case, they're conforming to the collecting system of the entire renal pelvis. Look, here's the ureter, here's the pelvis, here are major calyces. So this is what they call staghorn calculus. And here we have a couple of them. Whether it's from the same patient or not, I don't know, but it looks like it could be. So staghorn calculus is most likely magnesium ammonium phosphate, and which is not the most common type. I think I have another picture of it here. And let's see. Yeah, here's another one. Not only is this a huge staghorn, if you could imagine the horns of a stag, which is a male deer, You might say this is a staghorn calculus. And here, you're not looking at the dye in a collecting system. You're actually looking at the stone itself. And even though it's not calcium, it's dense enough to cause these densities on a regular plain film, okay? And the third type of common kidney stone is, of course, uric acid. And we've seen uric acid crystals damaging the tubules, but they can also be larger further down in the collecting system. And of course, we're going to be talking about the lower urinary tract in the next webinar. But the last thing we're going to be talking about in today's webinar are primary tumors of the kidney. Now, like all the discussions of tumors we had before, they could be benign, they could be malignant. Okay? The benign tumors of the kidney are generally, there's one that's epithelial looking. Okay, it's called a papillary adenoma. And of course, because it's benign, it's called adenoma. However, with the papillary adenomas, which clearly have a papillary configuration, size is very important. And one of the main things that would differentiate a papillary adenoma from a malignant glandular tumor of the kidney or adenocarcinoma is the size. So if you see an adenoma that's more than a couple of centimeters, you might be very, very concerned with it. You could have a tumor of the connective tissue of the kidney. You could have a tumor that involves blood vessel tissue and fat, but also benign appearing. You could have another type of tumor called an oncocytoma. And we see oncocytomas and oncocytes at many other places of the body. They are very large red granular cells. And you have to look at the reason why the cells are so red and granular from an electron microscope. There's usually a very, very big abundance of mitochondria in those cells. And from the malignant point of view, the classic, most common, premier type of malignancy, primary malignancy of the kidney, is something called RCC, or renal cell carcinoma. They have also been called clear cell carcinomas because much of their cytoplasm washes out when you do a regular H&E stain, because the tumor cells are often loaded with fat and glycogen, and these are two things that usually disappear during the histologic processing. The renal cell carcinomas have also generally been termed adenocarcinomas, okay? And another name that's also totally synonymous with renal cell carcinoma is a hypernephroma. I think nowadays probably the most common and most accurate term would just simply be RCC for renal cell carcinoma. But remember, once you get to the minor calyces and the major calyces and the renal pelvis and the ureter and the bladder, you now have a mucosa that is lined by a stratified transitional type of epithelium. The most might be called transitional epithelium in histology, but in urology, it's synonymous with the term urothelium. Now, there are parts of the body that have transitional epithelium, but almost all of the parts of the body that have transitional epithelium are part of the renal pelvis and collecting system, calyces, and lower urinary tract. So let's take a look at some of the pictures. Here's the benign guys, okay? Would you say that these structures here look like little fingers? They have a little connective tissue in the middle, like there and there, but they are covered with a cuboidal or perhaps low columnar type of epithelium. If I told you that was a hand and these are the fingers, would you say, well, this is the classical structure of papillary tissue or papillary tumors? So that's a papilloma. It's generally benign, otherwise it wouldn't be called a papilloma. However, the large papillomas are very, very worrisome, let's say more than 2 or 3 centimeters, and they are often more likely to be called adenocarcinomas. What about these cells over here? Take a look at them. They are really red, and they really have an abundant amount of cytoplasm. And I bet you if I blew this up a little bit more, I could convince you that the cytoplasm is also granular. Now, these are called oncocytes. And what makes these cells, which are called oncocytes, be big and red and granular? Because if you look under an electron microscope, they're very, very rich in mitochondria. Here's a renal tumor that looks like nothing but connective tissue. You know, fibroblasts and collagen, spindly cells. You know, they don't look terribly big or ugly or high mitotic figure. This is a regular old fibroma. Sometimes they're called hamartomas. And finally, here's a type of kidney tumor, generally benign. As you can see, it has these big, clear, open spaces that look like fat. And why do they look like fat? Because they are fat. And then you have these other open spaces that are filled with blood cells. So you know that these are blood-filled vascular spaces or blood vessels. And in addition, if you were to look at some of these spindly cells, like there and there, you could identify them by the usual type of methods as being smooth muscle cells as well. So, what would you call a benign tumor that had blood vessels, smooth muscles, and fat? Well, here's the angio part. Here is the myo part for smooth muscle. And here's the lipoma part for fat. So these are called angiomyolipomas. And they don't always have to have equal amounts of all three. Most of the angiomyolipomas I've seen probably had maybe 2 of the 3 types and maybe very little or almost none of the third type. But these are all the common benign renal tumors. Papillomas, oncocytomas, fibromas, angiomyolipomas. Now you know what we're going to be getting into. And these are the malignant ones, the renal cell carcinomas. The primary type of primary renal malignant tumor is called renal cell carcinoma. It has a very strong association with tobacco. Okay, even though you don't normally hear about tobacco causing anything except lung cancers, the association with kidney cancer is also pretty strong. They could be hereditary. In other words, somebody with a renal cell carcinoma could very easily have had family members that have or will get it. They are commonly called still clear cell carcinomas. Some of them have a papillary configuration, and you would think that might be called a papillary adenocarcinoma. If you look at the clear cell carcinomas grossly, they look yellow. Why? Because fat is yellow. And most of the cells which have fat, microscopically, the fat washes out so they look clear on routine microscopic exam. Now, does the kidney have lymphatics? Do you remember if the kidney has lymphatics? Not much, okay? I don't think the kidney has lymphatics. Okay, so the primary spread of a renal cell carcinoma is usually in the blood vessels. Okay, which means they are behaving probably more aggressively than in most of the other carcinomas. They tend to go to bone very early. they tend to go into the blood vessels or lung very early. So overall, renal cell carcinomas are not that good. Okay, here's some pictures again. Renal cell carcinomas, however, are very, very vascular. So when you see a normal kidney here, and you can see some branching of the renal artery going into two or maybe one or two little segmental branches, you can see a huge myriad of blood vessel branches here. That's probably why they're called hypernephromas as well, because they're very, very hypervascular. Here you have a normal kidney here on the right, and on the left you have something that is large. Perhaps it's necrotic in the center. Here you have grossly the fact that the tumors are generally yellow. So look, here's a renal cortex here, here's a renal cortex here, and here's the big tumor. It looks like it's about as big as the kidney. It's very, very yellow because the cells have glycogen and fat, and these are two things that wash out. So if you have a cell like in a glycogen storage disease or a fat tissue or any type of tissue like an atheroma that has fat inside of it, when you look at it microscopically, that fat is going to wash out when it gets passed through the xylene solvents. So this is the picture of the most common type of primary renal cell malignancy. But there is another type, okay, and it's called the transitional cell carcinomas, because the renal pelvis, the calyces, are lined by transitional cells. Transitional cells in the lower urinary tract are also called urothelial cells. So transitional cell carcinomas of the urinary tract are also called urothelial carcinomas. So when we talk about carcinomas in the lower urinary tract, in other words, ureters and bladder, and maybe even urethra, we're going to be talking about primarily transitional cells. But that transitional cell covering is also in the upper urinary tract, in other words, the renal pelvis. It's not nearly as common as the renal cell carcinomas, and has the same appearance, the same behavior as the urothelial carcinomas in the lower urinary tract. Of course, because they are now in the part of the kidney that is the collecting system, they're more likely to obstruct and bleed than the renal cell carcinomas, right? Because if you have a renal cell carcinoma, it's not going to necessarily show tumor cells in the urine, but most of the urothelial carcinomas, no matter where they are, would probably show tumor cells in the urine. Now, another thing, and the last thing that I want to mention before we leave early, is that this is true with cancer in general, but it's particularly true with the urothelial lining of the urinary tract. If you have a cancer in any part of the collecting system of the urinary tract, whether it's upper or lower, in other words, a transitional cell carcinoma, it has been subjected to etiologies all over the urinary system. In other words, if you find a cancer in one ureter or one pelvis or one bladder, you better very, very, very carefully examine in any way you can the rest of the urothelial line system, radiologically, surgically, pathologically, because when you have one transitional cell carcinoma somewhere in that collecting system, there's a high likelihood that it's another one. There was a pope, I forget which one it was. It was like about maybe 30 years ago. There was a pope that we learned had a urothelial carcinoma, and of course it was surgically removed and everybody was happy. And then he found out that he had another one in another part of the transitional lined collecting system. So It's associated with urothelial carcinomas elsewhere. Okay, I think we're going to show you a picture of that. Here is the renal pelvis. You can see parts of the cortex here, the medulla. But look at this whole renal pelvis is filled with a tumor, which could have started anywhere in the renal pelvis or even anywhere in a calyx, for example. And if you take a look at this microscopically, maybe I could even blow it up for you. Let's see. You can see that it's papillary because it has a central fibrovascular stalk of connective tissue. And then everything that arises from that stalk, all of these cells, all of these cells, all of these cells, these are the tumor cells, okay? And they can be graded in terms of how malignant they look, you know, like Roman numeral 1, 2, 3, or 4. Or you could say high grade or you could say low grade. But that's basically, we'll be dealing with that when we talk about the tumors of the lower urinary tract. Okay, we're done. It's only 10:30, so my 2-hour webinar was only an hour and a half today, and I'll try not to feel guilty, but I think we covered everything the way I wanted it to be covered. So, I guess that means we do our closing song, and you'll be glad to be done as well. Here we go. Final song for today's webinar, January 4th, Tuesday, 2022. Rock on, buzzards.